Welcome back, everybody. We're going to get started on our next conversation from a leadership perspective, focusing on population health and what the rapid advances that we've made, not necessarily in building technology, but adopting it and bring it into our health systems, has done to our workforce, has done, either beneficially or has created some detrimental effects. And we've got a couple of great panelists that can help talk with both angles. One is from an actual health system, what are the clinical transformation issues that have come up? What were the challenges? What were the opportunities? And Peter, Dr. Peter Pronovost is going to help us understand that from the clinical transformation perspective. And another really interesting perspective, which Amy's gonna talk to us about, is how have health systems like Ochsner been able to take some of these things from within their hospitals and health systems and in an entrepreneurial way, almost like intrapreneuring within the health systems and saying that, you know what, these technologies can really be taken from a health system like Ochsner and brought out to the outside world, maybe sold to others, spun out into new companies, et cetera. So nonprofit hospitals often are not seen as the most intrapreneurial or entrepreneurial environments, but Amy's going to correct that view for us today to show how Ochsner has been doing that. So without further ado, Amy, please introduce yourself. Tell us a little bit about what you do at Ochsner, and we'll do the same for Peter in a second.
Great. Hey, Shahid, so great to be with you today. My name's Amy Quirk. I'm with Ochsner Health. We are the largest nonprofit health system in Louisiana. We have operations all throughout the state of Louisiana and into Mississippi, with a 75+ year history of innovation. We're organized as a group practice, and a very strong group practice who has long championed innovation. So about 5 years ago, we formed a new company that I get the privilege of leading, called Innovation Ochsner. We call it IO. And it operates much like a startup within the health system that can really use entrepreneurial principles to create new care models and think about how we re-engineer care delivery to not just deliver health care, but to deliver health. And we've done that through a lot of different ways, a lot of digital health work, a lot of advanced analytics work, and then increasingly more personalized medicine approaches. And because at the end of the day, we really know that healthcare should be more proactive. It needs to be more predictive and preventative, personalized, and we need to engage our patients and consumers in the process way more to drive health. And so happy to be here with you today and talk a little more about the work that we're doing.
Yeah, I think we're going to learn a lot from you today, Amy, in this one area, and that is that your focus at IO being on the care delivery in order to move to actual health, right? Not new tools and technologies to increase or decrease the episodes of care, but really to say, okay, how do we actually take what we're doing to adjust the care model and move it towards better health? And that's awesome. I think, we think of health systems as a place where we go to get fixed up, not necessarily to get healthy. So that's great. And
no, we've, to that point, just down to interrupt, but just to that point, we've kind of said, we don't want to be a system that delivers health care. We want to be a system that delivers health. And that's really the transition that we're involved in down at Ochsner. So.
I love it. No, exactly. And Peter, from your perspective, especially as a physician working in a chief clinical transformation role, you've of course seen an enormous amount of change in the last 6 months, but have been working for many, many years before that on this kind of clinical transformation. So tell us a little bit about your job at University Hospitals and what you do in Cleveland.
Great. Hi. Thanks. It's great to be back here. I'm a critical care physician, and as Saeed said, I serve as the Chief Clinical Transformation and Chief Quality Officers. That means I get the privilege of running our nearly 600,000 patient ACO. It's about half the people we care for, so it's scale to matter. I run our employee plan, and I lead the evolution to value. So what does that mean, or what does that work encompass? Well, fundamentally, it's aligning the organization around a new narrative that success is keeping people healthy at home rather than healing in hospital. of galvanizing around some principles and an operating model to do that. And largely, what does that mean? Well, it's kind of along two fronts. One is we try to make visible and eliminate defects in value. Those are behaviors that we know right now could give better care, but we're not doing them. We have a piece coming out in New England Journal Catalyst saying those defects in value amount to an eye-popping $1.3 trillion a year, every year, and they're largely invisible. And then using technology innovation to even go beyond just those known behaviors, but how do we make it even higher value in the future?
Yeah, that sounds terrific. And what we're going to learn from Peter today is that ACOs are a mostly transitional model, we believe, over the next couple of decades as we move from fee-for-service to a hopefully more value-driven care model. And as we move to value-driven care, though, we still have an entire leg, not a foot or something, but an entire leg in the fee-for-service model. And we've got to figure out how do we take these new technologies, care delivery, et cetera, capabilities, and bring them so that groups can work together in this accountable care organization model and go forward. So let's start there. This is really, it's a very difficult thing to move from episodic to non-episodic and value-driven care. How has this, being an ACO influenced how you identify technologies, care delivery models, and then be able to know what to buy and what not to buy from a multi-group perspective? Because in ACO, you're not making a decision for one entity, you're making it for a variety of different entities over a care spectrum. What does that look like from your innovation strategy about how you identify and select business models, tools, technologies for the ACO, Peter?
Yeah, so great question. And let me just put it into context. You know, US spends heavily on technology and yet has negative labor productivity. Think about this. The only industry that has done that. We still have medical error as the third leading cause of death, and we still have far too many people dissatisfied or having negative experience. And so there's a lot of barriers to our current innovation market. What the ACOs do is they focus us to improve value. And by value, we mean the quality of care plus the experience of that care for the annual total cost of care, right? And that's the key, because every payer, that's what they care about. They're not looking about these transactional costs, or mostly what we do is income redistribution rather than value. In other words, the payer takes a bigger slice or the insurer takes a slice out of the provider pocket. No value is created though, because we didn't drop the annual total cost of care. ACOs have those incentives to do that. So what are the building blocks to doing that? And then what's our strategy? First, galvanizing the whole organization around a clear purpose to keep people healthy at home. Building an operating model that we break silos across the continuum so that we could literally make sure that people from the hospital to post-acute to ambulatory to emergency are all connected, and we're navigating patients to make visible and eliminate defects in value. That we have an analytics system, what we call knowledge processes, that not only make those defects visible, but provide real-time visibility into behaviors. And then finally, as part of our operating model, an accountability system to say at the end of the day, did you really bend the cost curve? So let me give you some examples of how those were using both technology and analytics and then innovations to drive this. What COVID forced us was to accelerate that journey to value. In other words, keeping people healthy at home with an unprecedented urgency. Why? Because we wanted to save PPE because we didn't have enough. So keeping a heart failure patient home rather than in the hospital. We wanted to reduce exposure to COVID when you came into the hospital. And we wanted to have capacity. So if a COVID patient could be cared for in their home without having to be in the hospital, it's a 10x to 20x less expensive. They get to sleep in their own bed, eat their own food, and be cared for by their loved ones. So what are some of the things we did? First, we used some analytics to make sure that people get home rather than to skilled nursing facilities. You all know the skilled nursing facility risks. Largely, that process was haphazard across the country of who goes to SNF. It's often made by a physical therapist without standard protocol. we put in decision rules that said home is the default. And if you want to send anywhere other than home, you have to have a decision rule. Mm. People going home went from 65% up to around 80% prior to COVID. With COVID, no one thought you can get even higher than that. It was now up to 87%, right? Mm-hmm. Urgency creates this laser focused, and our post-acute spend reduced about 30%, 37% actually. Readmissions went down and mortality went down. We also knew we needed to stand up technologies to keep people at home. And so we deployed, partnering with Massimo, some remote monitoring. But say, one of the keys that I think an ACO does is too often with our venture capital in healthcare, our innovation, it's a shiny object that might have some capital that we look to find a problem to solve. What we did is we flipped it, much like a systems engineer or you're an engineer, to say, here's the problem I have. I have low productivity. I have too many people being admitted to the hospital. And what technology do I need to do that? Because the reality is that technology is almost never a barrier. Almost all that we're doing in healthcare is a commodity in other industry. The real barrier is design and usability and scale. And that requires an at-the-elbow partnership between the technology company and providers to literally do agile everyday scrums. When we were developing that Massimo partnership, we literally had over 4 days, we went from FDA approval to first patient, but twice a day had scrums with the engineer. Think about that rapid innovation. It would have taken us a year before that. We wrote protocols, we pilot tested them on patients. Their engineers were right with us saying, I need this tweak, we need that tweak, giving us feedback on how we did it. And again, 4 days from FDA to launch of a new product.
No, that sounds terrific. And when you look at that model, what I love about it is the fact that you're seeing, and you call it, in fact, a defect in value. And so if you think about it, from like as an engineer, if we have a problem where a system is breaking down all the time, we don't talk about how to enhance the system. We say, how the heck do I get this from stopping breaking down? So we look for
exactly right
first, and then, like, if your car is breaking down all the time, you don't really care about changing the paint on it, right? That's what I love about what you're saying, is that if you call these problems a defect in the value, and you say, right now we're going to focus on defects, and once our defects are gone, then we're going to work on optimization and enhancement. Often I feel that health systems are looking for transformation, and they're thinking of it as an optimization activity. I'm like, what are you optimizing? You got so much stuff that's broken right now.
Exactly right.
You've got to go fix those things. And I think that terminology by itself, if nothing else, the audience should pick up on that terminology and say that defect in value is a driver there. The other thing that you guys have focused on, which I'd love for Amy to chat about, is this idea that you shouldn't be looking for the shiny object and figuring out where to apply it, but really think about what your strategy is, and then go find solutions or build your own. Like what I love what Amy and team are doing is they're not waiting for anybody to come up with the idea. They're like, we know we are a health system. We know what we need to do. We need to keep people healthy, and here's what we're going to do about it. So comment a little bit, Amy, on Peter's point of view on this defect, the value defect kind of model first, and then tell us, how do you go from where you guys are? You're a hospital and health system today, so you're still focused on episodic care. You're still focused on those kinds of legacy kinds of areas. But this movement towards health requires a significant change in the business model, how revenues are being brought in, how revenue is applied, how investments are being done. So just a quick comment on Peter's thoughts, and then tell us how IO is involved in this.
I think a couple things. The way that we've organized our system strategy has been around a few different pieces, but at kind of at the highest level, it's around areas that we need to reinvigorate, and those might be areas that we've been doing for a long time. Our destination care, we see people from all 50 states and dozens and dozens of countries for a lot of our specialty care and high-end care, but there are areas that we really need to reinvent, and that's our focus on digital health, on diversification, on personalization, continuous care models and on value. And we have a really purposeful focus on, we can't just fix the things and just think we need to optimize something. We have to just start over. And in some areas, so that we are really orienting around health. And so I think that there's a lot of parallels there. And I think Peter was also referencing sort of the idea of the triple aim, or I would say the quadruple aim as being sort of the North Star for value, right? You've got to obviously have those clinical outcomes and drive the health with a better experience, not only for the patient or consumer, but also for the caregivers while you're reducing the overall cost of care. And that needs to be our North Star as we're doing this reinvention. And so, as we think about that and think about what that looks like, at least for us at Oxnard and in IO, we start with a couple things that I think, if we were to think about how do we view reinvention and why is it successful, a couple different things is one, we start with a organizational buy-in and support, and we have that in our system. We've been, our part of the organization's been around for 5+ years. Our CEO, our board's fully invested, and fortunately we've got a great group practice who supports the work, who's open to change, who understands that the imperative is there, both the consumers and in terms of health outcomes, that we can do better and we can drive value. And so we've got kind of that right level of buy-in. And then two, I'd say, we've invested in a team and the talent to be able to give that sort of diversity of thought. That is focused on people who can help us not only on the clinical medical aspects, but can help us think about behavior science and on user experience and those types of things that are really important if we're trying to achieve that quadruple aim. And the other thing, and this maybe goes to the shiny object point, I think what's really important, as you think about reinvention, is you have to be focused on real world problems. That means starting with saying, what is the problem? Like, what do I need to do? And for us, one of the big issues that we've been very focused on is chronic disease. And it's a big problem, right? We all are dealing with it. And we keep seeing that how important it is. It affects so many people in the country. And it's unfortunately not a problem that's projected to get better with time. And we've kind of said, look, we're going to really focus on delivering outcomes in the real world. And sometimes that means you start kind of small and then you figure out how to scale it. And, what we developed is a continuous care model. So move away from that episodic model we talked about earlier, which in an area like chronic disease doesn't work, right? Because you can't look at 3 or 4 blood pressure readings, for example, in a year on something that is inherently dynamic and changes based on behaviors, based on any number of things, and expect to really move the needle. And so we've come up with a clinical grade, remote, fully virtual program that engages patients in their health, that uses home-based data, and we are all for pushing care and interventions at home. So patients have choices. Everything is designed around them and their schedules, as opposed to vice versa, which is the traditional way. And so we're getting home-based information that goes not only to blood pressure readings or glucose readings, but also all the other determinants of health, which we know now are really important. And we have the opportunity to collect and to be able to reach conclusions and make some predictions based on how people might do, and to take preventive action earlier and proactively. And deliver something that's personalized at the end of the day. And what we know is that achieves the quadruple aim. We achieve and sustain blood pressure control, A1C control in patients in this program. They love it. Our latest NPS score was an 87.5, which is kind of came in the COVID times, up from our last one of 78. So patients love it. Our doctors are loving it. And I think what we're seeing is that it also reduces the cost of care. And so those are types of things, those digital interventions. You asked about kind of getting stuff out. This is one that I think is core to the way that our system delivers care, but it doesn't have to be within our 4 walls. In fact, you never have to set foot on our campus to be able to participate and to get the benefit of it. And so we've been expanding it to new areas and through new different types of partnerships to reach more people, because we know it works, we know it makes a difference, and we know it really is what healthcare needs to be doing when we think about reinvention and not focused on shiny objects.
Yeah, I love that. In fact, Peter, as you think about it as an ACO, obviously you've got to be spending a lot of time thinking about chronic care as well. And so there's a few different parts of chronic care. One is the continuous monitoring. I think both of you have mentioned the at-home ability to do that. It's not great. Certainly better than it was a few years ago. Long way to go, because there's still a lot of automation that can be put into place. Not all the devices work all the time. People at home have difficulty setting it up, but I think those are solvable problems. The other area of chronic care management, both on the ACO side as well as what, Amy, you're doing at IO, is around the delivery model and the processes, procedures, how you train the workforces. Workforces today are trained for episodic care. They're not trained for chronic continuous care. So I know you guys have both done a little work. I'd love to get some comments on that. But first, I'd love to hear what are the reimbursement and revenue challenges with something that you know is the right thing to do. Like I've often said, in healthcare, there are no business models to do the right thing. You have business models to do episodic care. You have a bare bones set of business models for some value-based care, but there are no business models to do the right thing.
Yeah, so great question, Saeed. And going back to your point about just naming it a defect, people often bristle when they hear that, but there's system issues. A defect is some process or behavior that you don't want to have happen again because it reduces the net impact of value. And building on that chronic disease question, for defects for a chronic disease, for example, we separate defects into defects in staying well, so preventative behaviors, in getting well, chronic disease, and in getting better, acute care. But if you think about chronic disease, we might measure A1C, but if I have diabetes, the chain of defects is it diagnosed? 40% aren't even diagnosed. So whoever you're monitoring, we're missing almost half. Are they on the right therapies? Again, half aren't. Is their A1C, their lipids and blood pressure controlled? Nationally, about 10% of diabetics have they controlled. And have we avoided needless hospitalizations and ED visits? And again, 80% of diabetics have that. And so making those things visible, you could drive interventions that truly reduce annual total cost of care. But so let's go to business models, because I like to also push back that I think there is one business model on healthcare that everything's in line, and that is health system self-funded health plans. Because in those plans, we have full capitation. At UH, our health system is in network, so they get all their care here. We control the benefit design. We control the incentives for employees. We control the incentives for providers, and we control the care management programs, right? So those four levers are the tools you have to drive value, and we control all of them. And so that's our learning lab where we drive down spend. Now, it's hard to do programs for any one payer if you're on the clinical side, but I think there are models that we haven't tapped. Our strategy for the business side, and because you're spot on, with us, we have half ACO, so we have some financial risk, but incentives, but not full. But so those 30% of medical admissions, for example, that could be prevented if we eliminated defects, they're counted as a positive in our P&L right now because they're filling the beds. And so we had to get our board to understand, no, they're defects. Like, I get we have to balance the P&L, but our missions, our non-for-profit health systems weren't funded to fill the hospital. They were founded to improve the health of our community. So how do we navigate that? Well, our strategy is this twofold. One is we drive value, like I said, eliminating these defects. So I'll give you an example. This program that we did from 18 to 19, we reduced Medicare annual per member per year spend. Actually, some of this was just released yesterday, by 9%. Think about that. It's almost like a unheard of amount of reduction by tackling these defects, but that happened through ED visits and admissions and readmissions. So how do we do that? We at the same time make sure we keep care in network. With our ACO, we have, depending on what disease type, we have about 68 to 70% of our care in network, meaning 30% is going outside of it. And we measure it, that's part of the analytics systems, really, really carefully. So we say what percent of any encounter in Ohio was in our health system and what percent of the dollars in Ohio are in our health system. And so as we're driving out inappropriate utilization or, getting defects in value, we're keeping people in network. And most of it's because we build systems to improve value. And if they get care outside of our network, we don't have the data, they don't have the controls that we have to make visible and eliminate these defects. And I think the only way until we move to a full value-based system is to do this balance of making sure you're keeping all the care in network that you could, and you're making sure you eliminate these defects. And I can tell you, it's so rewarding for clinicians, because no clinician wants to be only on the RVU chain or admit these patients who they've admitted 10 times in the last year and feel good about it. I mean, they know their defects. That's what they went to medical school for, and they are passionate about eliminating them. One final point on that, you said something really careful about workforce. Though Amy runs a business, I run an organization, at least my view is we will only be successful if every employee in the organization believes they have two jobs: the job they were hired for and a job to improve value for those we're privileged to serve, right? And so every day, this idea of a flywheel are infecting a hunger where everyone's looking to make defects visible, to solve problems, to learn and improve, is the way we're going to get this kind of transformation that I think providers desire, patients deserve, and the payers are demanding.
No, that's very insightful. And in fact, as you think about that, what have you seen? You saved Medicare the 9%, that which sounds awesome. Medicare has, over the last maybe 5-6 years, been trying to incentivize health systems for everything from as little as the CPT code 99490 and the chronic care management, all the way to now managing and paying for continuous care. So Peter, have you guys seen any impact or additional revenue from things like the CCM program that Medicare put out, or is that not really bringing you guys much revenue?
Yeah, no, we absolutely have seen, and I think you make a really good point. Prior to COVID, our health policy viewed it had one lever: economic incentives, right? And doctor, if you're good, I'm going to pay you a nickel more. I'm going to pay you a nickel less if you're bad. And those have had, kind of variable response. They certainly haven't bent the cost curve at all. Right. What we saw with COVID, which was so exciting, was in using payment policy to stimulate innovation, competition, and value, right? Mm-hmm. So I'll give you my example. When we were trying to monitor for COVID, CMS you had to monitor 16 days to get paid for home monitoring. Well, we were monitoring these people 8, so we had no way to get paid for it. We were doing it, but CMS heard the pleas and they put the payment down to 2 days, right? So that was I think, really insightful payment reform, not to take a nickel out of our pocket, but stimulating innovation. They also removed regulations that were barriers to innovation, right? Whether it's providing home care or cross-state telemedicine. I think they withdrew about 400 regulations that were barriers to value and innovation. And I'd love to see, not just that I take a nickel away or give you a nickel more, but creating payment incentives that reward value, that allow us to keep people healthy at home and pay us to do that so that they're not healing in hospital.
Yeah, I love that. And in fact, Amy, as you think about what Peter just talked about in 2 areas, one is feel free to unpack more about the chronic care side, because I think that's where all of our spending is, right? It's not on the, elective surgeries through private payers is still a big segment, but a massive segment is on the chronic care side. So I just love to have you comment on what is IO's perspective in connection with Ochsner, the mothership, in terms of how much do you have to prove that a business model is sustainable before you get to work on it at IO? And in addition to that, where are you seeing the best business models that others, and what's nice is both of you are nonprofits. It's not like you're commercial entities that are nationwide making a lot of money. No, you guys are nonprofits who can manage communities, and you can make money in terms of revenue coming in, keep it sustainable. So talk about that, Amy, a little bit. Is what are you allowed to do or not allowed to do to continue to make that sustainable? And what are some new ideas that you guys have come up with that would assist in additional investments on the CCM side, chronic care management side?
Yeah, let me first kind of address your earlier question around incentives and some of Peter's comments, I think, around the way we've approached it and some of the progress that's been made around reimbursement for new value-based models that we know work, right? But I think, and I do think that there's been some progress, whether it's the CCM codes or all the 99490 and all of those other codes that have come thereafter. There's steps in the right direction, but I would say that we've got a long way to go with them. So for example, if we use them for chronic disease management, there's still a copay requirement. Right now that's been waived temporarily with COVID, but I think that that's a disincentive to people that may be on a limited income to paying 8 or 16 or whatever the amount dollars a month to participate in a program that hopefully they're not having to do a lot with, right? Because somebody behind the scenes is monitoring their information, reaching out as needed. It goes to my second point around a lot of the codes. They're still fee for service based. They're based on the amount of time that you spend rather than the outcomes you achieve. And, I think those are the things that we need to engage on to think about how do these models really create sustainable value-based models that aren't based upon, again, time. Because if you're doing everything right, you're leveraging technology, you're being proactive, you may not have to, time shouldn't be the sole measure, because that's really, truly, that's a fee for service based measure. And I understand it's clean and easy and harder, outcomes are certainly harder to figure out causal impact. But I think that's what we need to get to if we want to get incentives to really align with value. And I think that's a fundamental problem. And just like Peter said, we have used our capitated populations as the place where we start and learn and prove things out. And so to your question around like what we're allowed to work on and what we're allowed to do, I think because we're charged with reinvention, we're charged with really thinking differently and embracing whether it's new technologies, new research, just new care model innovation. We've got to try things new that are unproven, and we can have a theory, right? We're not coming up with nothing. We've got to establish feasibility and desirability and that there's some path. But ultimately, at the end of the day, we say, is this the right thing to do? If our North Star is the quadruple aim, if what we're trying to do is drive health, like, do we need to get here? And I think our value could be learning along the way, and then two, proving out a model that may be different than what is currently, allowed for reimbursement. And saying we're going to prove it out. And that's exactly what we've done in our chronic disease programs and our pregnancy remote programs. And really everything that we've done is kind of say, how can we start, which is not the best way to start because, it can be confusing for providers and for patients if you can only do it on certain segments of the population and things like that. And so we've had to learn around that to make it worthwhile. But once we learn that things are really working, as we have in our chronic disease programs, we've been able to sustain them because payers can see the proof, because employers, self-funded employers are seeing the proof and understanding the value of that. And so they're interested in participating in these types of opportunities to keep their workforce healthy and at work and, to keep their costs down over time. And so, you have to start somewhere. You have to start. I mean, I think that's kind of the exciting part, that we're all on this journey. And I think we're saying, no, we need to do better. We're excited about doing better. And so we're going to prove it out. And so I think, as we look ahead, and things that we're excited about working on, it is really about saying, how do we connect with people and help keep people healthy at home, wherever they are, and to create those connection points where people can have access to the care they need, that's personal to them, that anticipates their needs, and that helps solve those needs proactively and to prevent any hospitalizations. Because really our end of the day is we don't want people to have to come into our hospitals, right? We want people to be at home. And so, I think one of the silver linings of COVID has been that I think the acceleration that provided to, whether it's any sort of virtual care, whether it's on-demand urgent care or virtual visits or a lot of the remote monitoring and care that we provide, through our continuous care model programs, that both providers and patients really kind of got to acutely see the value of those things and helped accelerate the adoption, which is sort of one of the other barriers, I would say, in addition to into reimbursement, right? That you know, these things are new, and so there is a ramp up, and there's behavior change associated with it, and how do we get that to start happening? And you know, I think we're seeing some of that accelerate, but it's still going to be something that we continue to work on. But you know, I think our team is grateful that we're charged with producing change and delivering new care models and delivering new ways to benefit patients and to deliver health. And so, you know, we do our best to find those opportunities and to try to bring them to life in the real world and prove them in the real world. And that's what we are lucky enough to get to do every day.
No, that's terrific. And we've got only about a minute and a half before we open it up for questions here. I'll let you guys conclude with asking you a really, really hard question. And that is, at the top of the initial keynote at HealthIMPACT yesterday was focused on misinformation and what is the responsibilities of hospitals and health systems to help manage this misinformation crisis that we have. Do either one of you have any thoughts about, so the point that we made in our discussion at in the initial keynote was that that hospitals and health systems seem to have ceded the responsibility of health education, which used to be a big part of what doctors and nurses used to do before Dr. Google and Dr. Facebook came along, and everybody gets their information from social media and other things. What can you guys do from an innovation, population health, community health perspective to bring the hospitals and health systems back into the health education, health communication, et cetera, part of this? Any couple of pieces of advice as we then open up the questions for the audience? I'll let Peter go first, and then Amy, you can conclude.
Yeah, so that's a great question. At least what we're trying to work on is evolve from education, which is basically doing things to people, but ensuring competency in self-management. So how do I live with my disease given my social resources, right? And because we haven't taken into the social needs of patients, whether that's health literacy or food or housing or internet access, and the education, you're right, we've seeded it, but it's still very passive. Let me tell you about diabetes, as opposed to how do you live with diabetes and live well and thrive, making sure you know how to manage. And so our strategy is self-management programs that we give the consistent and same information at any touch point in our health system, because it was so inefficient and duplicative, where the hospital would make content, the primary care would make content, the specialist, home health would make content. It was all different and confusing as heck for people. Now, it may be subtly different, but what it said to the patient is you broke trust a little bit, and they didn't know what to do. And so by standardizing that, making sure it's very patient-centered, we think there's a great opportunity to re-engage with patients about their own self-management.
No,
and
I
that
love that.
includes
So
healthy behaviors.
Yeah, that sounds great. So what you're saying is, instead of trying to teach them in advance and hoping that they're going to remember, what you want to do is to be in the continuous learning part of it as well, right? That's exactly great, because if you're continuously monitoring, continuously connected with them, they can do continuous learning. That sounds fantastic. Amy, how about your side on misinformation and what?
Yeah, I mean, I think a couple of things. I think kind of it boils down to two main issues. I think one is access. You know, I think traditional healthcare systems have not kept up with the points of access that people expect. And that's why Dr. Google has become, you know, so prevalent in the space, because, you know, it's easy. It's right here. It's, you know, it's a click of a button and it's right there and there's access created, digital access. And so that's something that we're working on, coupled with issue two, which to me is personalization. You can't expect to give people just a generic after visit summary or whatever it is that you just give to them and they're expected to absorb it and whatever. I mean, none of us really read that, and it may not be personalized to me, delivered just in time, delivered in the way that I want it, and something that's of direct applicability to me. And so we have to get smarter about both the way we deliver things and what we deliver to ensure that it's convenient for people to access, and it is personalized and really just in time. And fortunately, I think that's an area where, we've been focused on in what we're developing is really making sure we're providing value to the patient and providing them information that they can have self-efficacy and make decisions based on their own and really become activated in their health. And that's an important area and a focus for us, and I think for many others as well.
No, I love that advice. I mean, it's so perfect. Peter talking about making sure it's continuous, and both of you saying that doing it on demand when you need it, that education, that learning, and then finally ensuring that it's personalized, I think then has a way of getting around getting around some of the misinformation that we're seeing. And with that, I'd love to thank you very much, Amy and Peter, both for some terrific advice here. And we're going to open it up now for questions. So please put in your chat messages and you'll get some quick responses. Getting some of the audience questions. So we've had folks jump in a little bit. So let's talk a little bit about the last couple of points that we made with respect to the business models and where Ochsner was allowed to go in and do some innovation. So earlier today, we had a number of questions around how does IT actually help or digital actually help bend the cost curve? Have you seen much in ways in terms of what Ochsner is doing to actually demonstrate that these digital techniques are reducing cost, the total cost of care in general?
Yeah. So in the case where I've talked about it in the chronic disease space, right, where we've been able to deploy a more continuous, completely digital virtual care model that allows for multiple connectivity points where we're getting 4 to 5 blood pressure readings a week as opposed to maybe one every quarter at best. We're able to actually make a real difference by providing real-time medication management coupled with lifestyle coaching that is based in a multidisciplinary team that includes health coaches as well as clinical pharmacists and advanced practice providers in addition to physicians. And so through that, what we've been able to study over time, and we've been doing that for 5+ years, we've seen because we knew we had to prove the value, right? Because these are new care models and you've got to prove the value of them. What we've seen is reductions in ER visits, inpatient admissions. We've seen increases in medication adherence, which of course is also a benefit in terms of reducing some of the adverse impacts and adverse events that could come from a condition like high blood pressure, like strokes and heart attacks. All of that reduces cost. And we've been able to validate that in a couple of different studies in which, we're able to meaningfully reduce on a monthly basis members' costs per month, in addition to the improved clinical outcomes and outstanding customer satisfaction. So yeah, absolutely. And certainly the use case exists in chronic disease, I think. And we've been able to prove that out. I think there are going to be other conditions and other types of modalities where we have to be looking for that proof and we have to prove out the value chain, but it definitely exists.
Excellent. And we've got about a minute left. So Eric has a question. What has been the impact of deploying innovative technologies regarding your clinicians and healthcare workforce's burnout and mental issues?
Yeah.
Do you have any examples?
Yeah, that's a great additional value that these types of modalities provide. One is in the chronic disease space, what we've been able to do is be able to provide a team that helps. In fact, our head of primary care said, has described our program as the easy button. It really adds value to our primary care practitioners because they're able to access a whole team that, is not necessarily managed in their office, but rather is a focus factory that's helping to provide this care to patients that is more personalized, more proactive than they're able to provide. So it'll take some work off the plates of the physicians and yet lets them know that their patients are being supported really, really well. Secondarily, in terms of workforce opportunities and physicians that are able to work with us, and since COVID, obviously many people have seen that working from home and doing kind of virtual care is actually really good. And we've been approached and been talking to physicians who are looking to be able to practice remotely more. And this in terms of a work-life balance situation is able to provide that as well. So if we're able to support, not just dump a bunch of data in front of the physicians, but actually manage that data for them and provide a great service to their patients, physicians are really seeing a lot of value from these virtual programs.
No, that's perfect. And we got two key tweetable things out of this conversation earlier with Peter. He mentioned defects in value. You mentioned the focus factory. That is awesome.
Yeah.
I'll give you the data so you can focus on things you need to. That is fantastic, Amy. We thank you for joining us here. We have to run to our closing keynote. Hopefully you'll be able to join us there with Peter.
Good to see you all.
We'll see you in a bit. Thanks as everybody on the audience. Please go to your agenda, click on the last session of the day, and we will see you there. Thanks again, Amy. Bye.
Bye.